The next topic I am going to talk about is about pacing in cardiac surgery. So before we go into the details of pacing, just a brief word about what the electrical system in the heart is about. We all know this is quite basic, that the impulse generator is SNO. The cardiac impulse travels along the right atrium and the left atrium, arrives at the AV node, and there is a usual AV nodal delay which is important for filling of the left ventricle or the ventricles so that they can pump adequately. And then the impulse goes through bundle of His across the ventricular septum, then divides into the right bundle branch and left bundle branch. The left bundle branch divides into the left anterior bundle and the posterior bundle. So there are two important things we need to know. One is the cardiac action potential. The cardiac action potential is something like this. The first phase or the zero phase, and the first phase is ion responsible is sodium, and then there is a plateau phase where when the muscle is repolarizing, the calcium ions delay the repolarization. So this is very important because this gives a sustained contraction to the heart, which is important for pumping the blood. And then further repolarization occurs because of the potassium. Now, to this point, around this point in the action potential, this is called absolute refractory period. Means another impulse coming and hitting the heart up to this point will not stimulate the heart muscle to contract again. Whereas after this point, it is called relative refractory period, wherein a stronger impulse can stimulate the heart. So we will come to the importance of this later and probably during the discussion of physiology and all those things. Now this corresponds to the ECG of the heart, which is something like this. So we need to know the difference between action potential and ECG. The action potential is basically the electrical stimulus that is making the muscle contract. So there is an action potential for atrium, action potential for the ventricles. What the ECG is doing is it's averaging out all the directions in which the electricity is going and giving us a recording of the gross electricity direction. So it's there are vectors and all. We'll discuss that later. But for today, what happens and how to go about pacing in cardiac surgery is what we will talk about. Often following cardiac surgery, for various reasons, the heart rate might vary, or patients may have arrhythmias, and either it could be bradyarrhythmias or tachyarrhythmias. And then in such situations, we may have to treat the patients to control their heart rates with drugs like amiodarone, cardarone, and ivabrad, beta blockers, and stuff like that, which slow the heart rate down, or for some reason if there is a graft occlusion or a post-operative, perioperative myocardial infarction, or for any reason if the heart rate is slow, then in those situations we have as a backup a pacing mechanism which we put at the time of surgery. So always in an ideal world, it is good to have the pacing electrodes on atrium and ventricle, because that would stimulate the heart just like the normal impulses. So at the time of surgery, what we do is many surgeons stick the wires on the heart epicardium in different ways. So it is always good to know how this surgeon in your unit is doing it, so that at the time of removal of the wires, you know exactly what to do. Some surgeons only prefer it to be cut because they have fixed it so in such a way that if you pull, it can damage the epicardium and make the patient bleed. Or some surgeons prefer the wire to be pulled out in its entirety so that they have only fixed it very lightly on the heart. Either way, you need to know from your surgeon how the epicardial pacing wire has been fixed, so that you know how to remove can be discussed. Basically about pacing, we are talking about now. There are different kinds of pacing boxes that you can get, and there is international body which monitors the pacing terminology, and based on their terminology there are actually 5 slots. The first one is the chamber to be paced. And second one is chamber that is sensed. Third one is what happens once either the box senses the activity, and very often there is a response, a reactive response, this thing, and O. And then there is usually a fifth one for defibrillators. Now, usually we don't care about these, and we only talk about the three in routine terminology. So there could be if we are pacing the atrium, the chamber to be paced is atrium. The chamber that is sensed is atrium. And what happens if there is an impulse is, if the pacing box inhibits itself, then it is called AAI. If the pacing box does not do anything, it is called AAO. And there could be different permutations and combinations. So here the possibilities are AVO and again AVO, and here I and O. So you can have atrial pacing and D as well. So there could be atrial pacing, atrial sensing and inhibition. Atrial pacing, atrial sensing, and nothing needs to be done. Ventricular pacing, ventricular sensing and inhibition. And ventricular pacing, ventricular sensing, and the pacing box does not do even if it senses anything. And dual chamber paced, dual sensing and inhibition, or do nothing. Of all these permutations and combinations, the most common combinations that we use are AAI and VVI and DDD. Very often you can sometimes see VOO and AOO, basically where we are pacing irrespective of whether there is an impulse or not. But these are traditionally not to be used because they can be dangerous. We'll talk about it later. So now what is this AAI, VVI and DDD, and when should we use them? So if a patient has got bradycardia and his heart rate is say less than 60, which is what we want, the heart rate, usually normal heart rates fluctuate between 60 and 90. So we want the heart rate to be between 60 and 80, but if it is less than 60, and if the patient has got a sinus bradycardia with normal conduction of AV conduction, then the best methodology will be to do AAI. Because with AAI, you will stimulate the atrium and the stimulus will go to the AV node and then gets conducted just like a normal electrical impulse. So the whole idea of pacing is to try and get the physiology to as close to normal as possible. So what we do is, if there is bradycardia and normal AV conduction, AAI is the best modality because this will simulate like a normal sinus rhythm activity. Say if the AV conduction is not there, then if you just pace the atrium, what will happen? Nothing will happen because it will come and because the AV nodal conduction is not there, the impulse will not get conducted into the ventricle. So it is of no use. In such situations, what we should do is, if AV node is gone, then DDD will be the best modality, because in DDD what happens, we are pacing both the chambers and you are sensing both the chambers, and then it can either inhibit or it will not inhibit itself based on the sensing. So for instance, if a patient is in complete heart block, in complete heart block there is a complete dissociation between atrial impulse generation and the ventricular impulse generation. So in complete heart block, if a atrial impulse comes at the normal rate at 70, then the pacing box will inhibit, the atrial part of the pacing box will inhibit itself, but it will stimulate because it senses the atrial impulse, it will inhibit itself, but if it doesn't sense the ventricular impulse, it will fire at 70 per minute, and whenever it finds a ventricular impulse, it will inhibit itself. So a DDD modality is the best mode in complete heart block, and AAI in sinus bradycardia. Now there are situations like atrial fibrillation. In atrial fibrillation, what happens? The atria are fibrillating at heart rates of more than 250 beats per second, or it is basically the each muscle fiber is just beating on its own, and it's complete dysynchrony, or there is nothing called a synchrony. In this situation, unless you in AF and atrial fibrillation and atrial flutter, unless you stimulate the atria at heart rates more than 250, you will not be able to overcome the rate of atrium, and so there is no point in pacing the atria, because at 250 beats per minute, it's as good as ventricles also. If they fibrillate at that time, there will be no BP at all. So there is no point in pacing the atrium. In such situations, VVI is the best modality, because we cannot stimulate the atrium, but there will be AV dissociation, and ventricles are firing at their own rate. And if it is too slow, if the ventricular response rate is too slow, then a VVA pacing, wherein if the ventricular impulse comes, it will inhibit itself, but if there is no impulse, then it will stimulate the ventricle. This kind of modality is the best modality in atrial fibrillation. So the common situations where you will need pacing is in bradycardia. If it is sinus brady, use AAI. Wherever there is a normal AV conduction, use AAI. If there is no AV conduction, and in situations like complete heart block, DDD is best. And in situations where atrial fibrillation is there, even if the ventricular rate is fast, even then, if you put only ventricular pacing wires, then in the post-operative period, when you control the heart rate, and if, say for instance, the heart rate comes down, then we can still pace the patient with VVI. So these are the three modalities I want you to remember as far as the pacing is concerned. Now, how to make the connections? We know electrical current goes from positive to negative. So on the pacing boxes that you have, now depending on how many chambers they can pace, they are called single chamber pacing box, and there are dual chamber pacing box. So in a single chamber pacing box, there are only two electrodal points. So when at the time of surgery, if the surgeon has put pacing wires on the atrium and the ventricle, and normally because the right ventricle is the one that faces the anterior part of the anterior part of the heart, the pacing wires are placed on the right ventricle in the right atrium. So traditionally, the atrial wires are brought to the right side of the incision, and ventricular pacing wires are brought out of the chest on the left side of the incision. So in a single chamber pacing box, there is always a plus and a minus, which one? There could be black and red usually. So when these pacing wires come out, you need to attach these to the pacing leads and then connect them to the pacing box. Very often surgeons don't put two pacing wires, they put only one pacing wires. So that is called as a different lead. Now the different lead is the one which paces, and the indifferent lead is there only to complete the circuit. So in the leads you can call different and indifferent. And different is the positive one, which is the pacing lead, and indifferent one is the red one or the negative one, which only is there to complete the circuit. So if there is only one pacing wire, then what we need to do is connect this to the black of the pacing box, black lead of the pacing box, because that will be the stimulating one. And then you need to insert a hypodermic needle, a green needle or something under the skin, and attach that end to the negative this thing, so that a circuit is completed between the heart and this thing, and then we can stimulate. But usually if you use such a circuit, the amount of voltage that you need sometimes will be very high to stimulate the heart. And hence, if at the time of surgery, if the surgeon suspects that there is a possibility of heart block or bradycardia, then they usually put two pacing wires on the atrium, two pacing wires on the ventricle. And when you connect these to different and indifferent lead, that creates a smaller circuit, and so the heart can be stimulated with lesser voltage. So now in AAI, what we need to do is so if this is black and if you got AAI pacing, always the lead that is there on the heart should go to the black. And if there is no lead on there is no other lead, a skin lead can go into the red one. This is good for AAI. If we are having VVI, then there is only one pacing wire. Then what we need to do is the pacing wire that is there on the heart should go to the black, and the pacing wire or if there is a hypodermic needle on the skin, that will go to the red. If there are two pacing wires on the RV, then you can connect either to whichever lead, and then that can cause the or we can pace the patient in whenever needed. Now, it looks like positive.
Okay.
So I'll demonstrate to you what I've been talking about till now. So this is a pacing lead, and as I said, it has a red and a black end. The black end is usually connected to the positive and the red to the negative. And black is the different lead which is going to pace, which is going to stimulate the heart, and the red one is the indifferent one which is only there to complete the circuit. And so these have a corresponding ends where the needles of the pacing wires can go. So whenever you need to pace a patient, there will be a couple of wires coming out of the patient, and at the end of those wires there are needles, blunt needles, which go into this end. And once the needle is placed, then you can tighten it so that the needle will not come off easily. And so if you have two pacing wires, you put the two needles into each of these. If there is only one, you select the black one for the different lead, and then put a hypodermic needle and connect that to this one directly, so you can allow the needle to go into this hole and tighten it. Once this is tightened, the patient is connected to the lead, and the other end has got two needle ends which go into the pacing box. So this is a single chamber pacing box. Of course, this is a very old model that we have got for demonstration here. But here there will be a plus and a minus. So the plus one should always be the black one, and the minus one is always the red one. So once you connect these and you make sure that they are properly in place, then what you have on the face of it will be 3 or 4 buttons. One is a button to switch it on, which will ensure that you will start getting the light. And second thing is which is called as output, which will determine how much volts of energy is being given to the heart. Then there another button which will tell you what rate per minute you want to pace the heart. Another one which will tell the sensitivity, means you can set the sensitivity at the lowest, so that even a tiny impulse that comes off the heart will be sensed by the pacing box and can be used in the VVI and AAI modalities that we have talked about. And they will have usually a rapid pacing one, which normally we don't use, but it's a specialized use. We'll discuss it at a later time. So these three are the important things. So once you connect the patient, then you set the rate, something around 80 to 100, and then you set the voltage, usually up to 10, and then set the sensitivity up to the least, which will be 1, and then you're pacing the patient. So it is a very simple mechanism that can save lives, particularly in a patient who is going into bradycardia or asystole in the post-operative period, in cardiac surgery. Many centers, and in our center too, whenever there is a doubt, the surgeon would have left pacing wires. So whenever the heart rate is going below 60, or if you suspect that the patient might go for a asystolic arrest, in such situations, better rush, make the connections and start the pacing, and so that you can start pacing the patient. Now, this is the single chamber pacing box. Now there are similarly there is something called as a dual chamber pacing box. So this is an example of a dual chamber pacing box. In dual chamber pacing box, you will have 4 sets of leads, 2 for the atrium and 2 for the ventricle. Again, there is a black and a red and black. Of course, we have lost the black knob of this, but this is supposed to be black. And if you see the stimulation thing will be usually by convention. The first one will be atrium, the second one will be ventricular leads, and the plus and minus can be variable, so you need to make sure that you know plus is there different lead. And in this pacing box, and in any pacing box, you need to know how to switch it on. So if there is usually the normal standby or switch on button will be there. When you switch it on, the pacing box switches on and it has got a default mechanism built in. So in this, the mechanism that is there, it says ODO. So it is just sensing and then not pacing. So if you select which now this is selected the heart rate, and then there are plus and minus, so I can increase the heart rate. And equally, if you select the modality into which you want to pace, there is AAI, DDD, VVI. So we can select the modality and then the rate, and then so now it's selected VVI, and the stimulation at which how much stimulus I can give, I can select that and increase or decrease it by using these minus and plus buttons. And the stimulus at which it senses also can be adjusted by selecting the respective button. So I've set it to the minimum, that is 1, and set the stimulation at 7, and the heart rate I've set is at 76. So now the patient is being paced VVI at 76 beats per minute, and this pacing box will sense if the ventricular impulse is of 1 millivolts strength, and it will inhibit itself. If it doesn't find an impulse coming from the ventricle, it will start stimulating at 76 beats per minute. So this is a very good modality in using in patients, particularly in atrial fibrillation. So similarly, we can change the modality, but of course it has got a self-locking button. And so these are the 3 modalities that are there: DDD, AAI, and VVI. So before you select or whenever you posted in a cardiac ICU, familiarize yourself with the pacing boxes and know how to operate them, how to make the connections, and once you start pacing, you will see the pacing spikes on the monitor, and make sure that the pacing is working properly. And also, when you start pacing, it is very important to know whether the pacing is helping the patient or not. Because with each pacing beat, if there is no arterial pulse trace, then there is no point in just pacing. So you should see that there is a corresponding arterial trace, which means the heart is really pumping blood and it is helping. If it is not helping, then the problem is more serious and it needs expert help. So again, I will recommend you to go through the reading of pacing, familiarize yourself. Cardiac surgery is one faculty where you can really save lives if you know how to deal with the pacing and pacing box in the post-operative period. Once the patients are out of danger, usually it will be 3rd or 4th post-operative day, and usually 5th post-operative day, by which time all the myocardial edema and everything would have settled, and so any pacing related problems are very unlikely to happen after 5 days. And hence, usually on the 4th post-operative day, we tend to take the pacing wires out. And before you take the pacing wires out, you should always check the clotting of the patient, because many times pacing wires are put in patients who have undergone valve replacements, and both the AV node, bundle of his, and left bundle branch are very close to the aortic valve and mitral valve annuli. So when we take big stitches, sometimes there could be temporary heart blocks. And these temporary heart blocks are treated with pacing. And before you taking the pacing wire out, you should make sure that by switching off the pacing box on a monitor, the patient has got his own intrinsic rhythm, and he's got good blood pressure with his own intrinsic rhythm, and that he's not in some kind of heart block. So at least monitor for 24 hours before you plan taking pacing wires out, and also get a ECG done off pacing so that you can record that the patient is in sinus rhythm before taking the pacing wires out. If the rhythm is not sinus, if there is if there are episodes of bradycardia, if there are any other concerns, please consult your senior before you consider taking the pacing wires out. And patients who had mechanical valve replacements or patients who had valve replacements, often they are put on acetylene, and so their clotting will be deranged. If the INR level is less than 2, you can safely take the pacing wire out without possibility of patient bleeding internally. If the INR is more than 2, then consult your senior whether you should take it out or not. Some consultants take the pacing wires up to 2.5 of INR, but in our unit we prefer to take the pacing wires out only if the INR is less than 2. So before taking out the pacing wires, check patient's rhythm is okay, check that he is not pacing dependent, check by doing an ECG what kind of rhythm he is in, check his INR, that his INR is less than 2, and then only resort to taking the pacing wires out. If in case of any doubt, please consult your seniors and do not take the decision by yourself, and unless and until you are really experienced in it. Thank you.